All right. Hello, everybody. Welcome to Grand Rounds on this Monday afternoon. We are delighted to welcome back Dr. Isabel Preeshagul, who was a resident here, now is an assistant attending on the Thoracic Medical Oncology Service at MSK, where she focuses on research on predictive and prognostic biomarkers for response to immunotherapy and targeted therapies. And that's what she's going to be talking about today. Dr. Preeshagul, thanks so much for joining us for what I hear is your first ever Grand Rounds talk.
Yes, and thank you so much. I'm extremely excited to be here today. It feels like coming back home. And I look forward to going through this talk and, of course, interacting with you after, hearing about your questions. Feel free to put them in the chat, and then there'll be about a 10-minute question answer session after. So is it all right if I get going? Okay. So today I'm going to be talking about targeted therapy for lung cancer, all about tailoring to your tumor. These are my disclosures. Here's a brief outline of what I'm going to be talking about. First is going to be just the evolution of lung cancer treatment, talking about what next generation sequencing is. I don't know if you've heard that term, but I'm going to explain what it is. Talk about who should get this next generation sequencing testing, the different modalities for testing in tissue and liquid, some of the barriers that we face to testing, frontline treatment options based on next generation sequencing testing, second line treatment options, early and locally advanced stage treatment options, and then some take home points. So we have a bit of a tour de force, but we will get through it. So let's look at the evolution of lung cancer. So way back when, probably 30, 40 years ago, lung cancer was treated just as a solitary thing. You were diagnosed with lung cancer, you got treatment X. And as time developed, we realized that lung cancer is much more complex than just, one size fits all. It's stratified based on histology, non-small cell versus small cell, and even further subdivided to adenocarcinoma, squamous, large cell, neuroendocrine, the list goes on. And as you can see the arrow moving to the right, we now focus on molecular pathology. Is your cancer driven by any mutations or fusions? And also PD-L1 expression. So I will go into all of this in detail. So clearly, as I had mentioned, lung cancer is complex and one size does not fit all. Here are two main objectives that I just want you to feel comfortable with when we are done with this talk. And it's really just understanding what next generation sequencing is, and also understanding the difference between tissue and blood-based next generation sequencing testing and the value of both of those. So what is next generation sequencing testing? I'm going to say this word a lot, so you should get familiar with what it actually is. So what it is it's large-scale DNA sequencing technology that allows us to query the entire genome, which is the whole genome, or exons within your known genes, known as whole exome, or only exons of selected genes, known as a targeted panel. So this is done on the tissue biopsy that's taken out from your tumor, and it can also be done in blood-based testing. And I'll go through the differences between both of these, but basically we are looking to see if there's any mutation that your tumor made all on its own that's driving it to grow. And we're trying to see if we can target that mutation. And that's the point of this testing. So this testing should be done on all patients diagnosed with non-small cell lung cancer. So why is it so important? Well, it ensures that we have the correct cancer diagnosis, which is going to impact decisions regarding treatment, surgery, radiation, chemotherapy, the list goes on. And it's also important to understand a patient's risk of recurrence and to have some maybe challenging prognostic discussions with your patient. And it also can assess for heritable germline mutations, right? So we have somatic mutations, which are mutations that your tumor decides to do all on its own. And then we have germline mutations like BRCA and the APC gene that you got from mom and dad and could pass on to your children. So how does next generation sequencing impact our patients? Well, if we find a target, it can help us know what the right targeted therapy is for that patient. And if we don't find a target, then these are the exact patients that we know we need to search a little bit deeper on, which I'm going to get into. So who should get tested? Basically everybody. So you have a patient that's diagnosed with non-small cell lung cancer, and this is a very simplified model. I could talk all day about this model alone, so just bear with me. But basically, you have a patient that's diagnosed with non-small cell lung cancer. They should have molecular testing with next generation sequencing, and they should also have their PD-L1 level checked, right? So let's go down the green pathway first. Let's say we do next generation sequencing testing and we find a mutation. Great. This is a patient that is a great candidate for targeted therapy against that mutation to fight their lung cancer. But let's say we don't find a mutation. So then we need to look at PD-L1, which is a marker that grows on our cancer cells. And if this marker is greater than 50%, then most likely immunotherapy alone should be involved in this patient's treatment. However, if the PD-L1 expression is 1 to 49, then we're looking at some kind of combination chemotherapy and immunotherapy for this patient. The take-home point from this slide is that if you have a targetable alteration, if your cancer has a mutation, it does not matter what your PD-L1 is. That mutation trumps everything because those patients do better on targeted therapy. So that is the take-home point. So I'm going to be talking about targeted therapy for the rest of this talk. So we're going to be focusing on this pie right here. So let's talk about the different modalities of next generation sequencing testing. And first, we're going to start with tissue. So here's kind of a schematic of what happens. You have a patient, you see them in clinic, they have a big left upper lobe lung mass. You get this tissue biopsied from their lung, you send it for next generation sequencing testing, and then you get your next generation sequencing report. And this tells you if there's an actionable mutation or not. You take this information to the clinic, review it with your patient, and talk about treatment options. So old school, we used to do this testing with various different modalities. To look for point mutations, we used to do the Sanger sequencing or immunohistochemistry. To look for various deletions, we would do Sanger or IHC, as you can see, or multiplex sizing assays. It was just a complete mess and very complicated, and things would get missed constantly. Hence the development of broad hybrid capture next generation sequencing, which can identify looking for all of these things in one foul swoop. And this actually increased the actionable drivers that were detected. They do have, outside of this broad hybrid capture, some smaller practices, some community practices will do what they call a targeted based panel, where they only look for some of the most common mutations, but this is not the right answer because you miss the more rare mutations and you're affecting a patient's life. So a targeted panel only is not acceptable. It needs to be broad-based next generation sequencing. So why do we need to do this next generation sequencing? Because as you can see here, starting in 1999, we really didn't know anything about mutations at all. And then fast forward to 2021, and we have more mutations and targets than I can even count. So hence the importance of getting this testing done. So let's talk about the blood, because we just talked about how to do this deep testing on tissue. So I'm going to walk you through this diagram here. The big red stripe is a blood vessel and the pinkish blob on the left is a tumor. So as you can see here, you have this tumor that's releasing tumor DNA into the circulation here. So this patient comes to clinic and you draw 2 test tubes of blood. And sometimes you can pick up the tumor DNA in the bloodstream. And this allows you to detect for the presence of a mutation even faster. So what are some of the advantages of doing a liquid biopsy instead of a tissue biopsy? Well, it's minimally invasive. It's just a blood test instead of just doing tissue. It's a faster turnaround time. We're talking about 7 to 10 days, as opposed to next generation sequencing on tissue, which can take up to 4 weeks, which is a hard pill to swallow to tell a patient. You can also overcome tumor heterogeneity, which means if you have a tumor and you pass a needle through it, you may be missing the area where you have most of the tumor cells and the bulk of the mutations lie. It can increase the rate of biomarker detection. And it also may be used prospectively in the future to detect response to treatment or presence of circulating tumor DNAs to kind of get a sense of how well this patient's doing, or do we think this cancer is coming back? So let's talk a little bit about some of the limitations of liquid biopsy. The sensitivity is not as great. We're looking at 70 to 80% and specificity near 100. Unfortunately, if your liquid biopsy does not show a mutation, it does not mean that your tumor doesn't have a mutation. It just means that that tumor did not release the mutation into the bloodstream. So it may warrant you to get another biopsy to really be certain. Also, liquid biopsy cannot detect for PD-L1. So there was a study done called the NILE study, the non-invasive lung cancer study. And this was a prospective study that was done on 282 patients with untreated non-small cell lung cancer. And they found that adding liquid biopsy looking for cell-free DNA increased the detectable and identifiable guideline recommended biomarker targeted therapy options by 48%, which is huge. So next generation sequencing on all of your lung cancer patients. So let's talk about some of the barriers. I could discuss this slide all day long, but I'm going to focus only on the two that have stars. We're going to talk about access to testing, and we're going to talk about awareness of testing and how to actually interpret the results, right? So as I had briefly highlighted before, tissue is sometimes an issue. Sometimes the biopsy can't be obtained safely, or the tissue was insufficient. So that's where you would rely on liquid biopsy. I had mentioned the turnaround time of tissue takes about 4 weeks. So liquid biopsy might be a little bit more attractive. Payment and reimbursement, sometimes, out in the community, it can be confusing how much this is going to cost. What lab do we use? So the list goes on as to excuses and barriers as to why we can't get this testing done. So let's talk about some of the racial disparities that we have. So this was a very large retrospective study that was done looking at 14,000 patients with non-small cell lung cancer. And they actually found that the overall rates of biomarker testing was really low, like 76.5% of patients were ever tested, and only 48.7% of those got the full broad-based panel. So less than 50%, which is really embarrassing and terrible. So as you can see, the rate of next generation sequencing testing is not as high as it should be. And then when actually stratifying it to look at patients that are Black versus the white patient population, it was significantly lower in the Black population, 39.8% versus 50%. And then we also went on to look to see if the rate of clinical trial participation by Black patients was less as well as a result of this. And it was actually 50% that of the white patient population. So how can we remedy this? We can increase awareness of what next generation sequencing testing is and the importance of it, which is exactly what I'm doing today. Even if one of you leaves here and happens to have a patient or knows somebody, or God forbid your family member is diagnosed, and you remember this word next generation sequencing testing, you could be saving someone's life. So don't forget. So let's talk a little bit about awareness of the testing, which we just went over, and how to interpret the results, right? So you get this 36-page next generation sequencing document, which is completely overwhelming to me as well, even though I'm interpreting these on a daily basis. So we have this data tsunami, right? So what do we do with all this information? This can be daunting. How do I know if I need to refer a patient? Is there a trial? It's very unclear. So that's why I'm going to walk you through what to do with all of these targets and all of this information. So let's start with the frontline targeted therapy options in stage 4. These are all oral agents, which is very attractive for patients, and it's life-changing. So these are all of the targeted therapies that have approval. The ones that are in green are the ones that are approved in the frontline setting. So I'm going to walk through the green ones first, and then we'll go on to the black ones. So let's start with one of the most common mutations called EGFR. I'm not sure if you've ever heard of this before, but I'm sure you've seen a patient with an EGFR mutation on 9 days in, get admitted, that's on osimertinib with a rash or diarrhea or toxicities. So we're going to talk all about that. So EGFR mutations are seen in about 10% of patients with non-small cell lung cancer. It's very commonly seen in patients that have no smoking history or a very minimal smoking history, commonly seen in the Asian population and in women. There are 3 main mutations: exon 19, exon 21, which is L858R, and exon 20. And I'm going to talk about just exon 19 and 21 for now. So the main drug that's approved is a drug called osimertinib or Tagrisso. It's a pill that you take once a day. It has an 80% overall response rate. This drug, when it was approved based on the FLORA study, blew every other pill in this space out of the water. It's well tolerated. The main side effects, as I'd mentioned, are rash and diarrhea, and it actually can be severe. So here you have a patient with an osimertinib rash. You can see grade 1, you just treat with steroids. Grade 2, steroids and clindamycin gel. But grade 3 and 4 can be pretty significant. I often hold the tyrosine kinase inhibitor, which is osimertinib, start steroid cream, clindamycin gel, oral antibiotics, and oral steroids. And if it gets really significant, you may not be able to give them this targeted therapy again. So try not to ever let it get to that grade if you possibly can. Next, we're going to move on to our next mutation, which is BRAF, as you can see highlighted in red. BRAF V600E is a mutation that's seen in many different tumor types, but it is also seen in lung cancer. You might have heard about it in GI malignancies, but we're going to talk about it in the lung cancer space today. So BRAF is not as common as EGFR. It's seen in about 1 to 2% of non-small cell lung cancer patients. And there is really only one ideal drug regimen confirmed and approved in this setting in stage 4, and that's combination dabrafenib and trametinib. So these two pills actually have a very interesting side effect. While they do cause the main side effects that chemo pills do cause, nausea, vomiting, upset stomach, bringing your blood counts down, putting you at risk for infection, they cause pyrexia or fever. And this happens in about 55% of patients that are on this medicine. And it can be really kind of scary. So imagine you're in the emergency room, you have a patient that comes in with a fever of 104. You're of course thinking infection, you're thinking, are they septic? What is this? Is it COVID? Who knows what? Is this neutropenic fever? And then you see that they're on dabrafenib, trametinib for their BRAF mutated lung cancer, and you should have a light bulb go off in your head that says, oh, maybe this is a side effect from the medication. So for these patients, we treat them with antipyretics, Tylenol, NSAIDs, and we also treat them with steroids if the fever remains above 100.4. Or if this is a second or third reoccurrence. But we try our best to keep these patients on drug and not hold drug if we don't need to. The fever usually resolves. So I'm going to move on to talking about fusions now. We were just talking about mutations. So we're going to talk about the fusions, which are highlighted in yellow. And these are still stage 4 frontline therapy options. So why are fusions so important? So sometimes they can be tricky to detect. So you run next generation sequencing on this lung cancer patient and you don't see anything, but you're like, well, this patient has no smoking history. I feel like they're going to have a mutation, or I feel like they should have something. That's when we need to request for RNA-based sequencing. And I'm going to talk to you a little bit more about that. But sometimes these fusions can be missed on first pass impact testing, which is our in-house next generation sequencing. So we run our MSK fusion, which is RNA-based testing. So impact is DNA and fusion is RNA-based testing, and RNA-based testing has the capability to pick up on these fusions, which can be missed very commonly. So ALK fusion. ALK fusions are seen in about 4 to 6% of patients with non-small cell lung cancer. And there are 5 pills that are approved in this setting, but really only 3 in the frontline setting have very convincing data: alectinib, brigatinib, and lorlatinib, as you can see listed here. Lorlatinib is special because it's known for its ability to penetrate into the blood-brain barrier, which I'm sure you've heard before is very difficult for chemotherapy to get in there. So if you have a targeted therapy that can get through the blood-brain barrier and treat any metastases that have gone to the brain, this is a home run for all of us. Unfortunately, as you can see on the right side of the graph, they are not without toxicity. So alectinib can cause myalgias, it can cause weight gain, which can be pretty significant. Brigatinib can cause pulmonary events like pneumonitis, and lorlatinib can cause your cholesterol to go up. It can also cause weird neurological side effects, and if you have really bad depression, it can really turn that going in the completely wrong direction. So we need to involve our psychiatry colleagues really closely for those patients with an underlying psych history that are going to be treated with lorlatinib. So I'm going to move right on to MET exon 14 splice alteration. So this is a also more rare. It's seen in about 3% of patients with non-small cell lung cancer. And these are the drugs that are approved in this setting. Capmatinib and tepotinib seem to be sort of trailblazing as of right now. I don't really have a preference between the two. The efficacy is somewhat comparable. I tend to choose capmatinib more so because I'm a little bit more comfortable with it, but it doesn't mean it's the right answer. But as you can see, the toxicity is legit here, and edema or weight gain is very significant. I had a patient on this drug that gained 45 pounds, and you would think, oh, you know, you have a cancer patient with cachexia. This is great. They're gaining weight. They're doing good. But no, it's like significant. And we needed to involve our endocrine colleagues. You can start them on compression stockings, diuretics, diet modification, but we ended up having to actually reduce the dose. And this patient ended up not even being able to tolerate the drug. So this side effect is rare, but can be quite significant. So we'll move on to ROS fusion next. ROS is also more rare. It's seen in about 1 to 2% of patients with stage 4 non-small cell lung cancer. These patients are typically a little bit younger, no smoking history or a very light smoking history. And the two drugs that are approved in this setting are crizotinib and entrectinib. Entrectinib is the one that has good penetration through the blood-brain barrier. And one thing to remember, which actually was a board question, it might have been on the medical oncology boards, but that crizotinib can cause visual disturbances. So that's something that's very strange, but it's a weird side effect to remember. So if you have a patient that gets admitted and maybe is having hallucinations, you might want to just double check that they're not on this medication. I saw it one time in fellowship, but you only need to see it one time to remember it. And next, we're going to move on to RET fusions. So you've probably heard about RET fusions. You might think about the thyroid. You might think about medullary carcinoma. You might think about Rett syndrome. And this is a very similar gene that's found to be fused in non-small cell lung cancer. So pre-2017, our RET inhibitors were really they were dirty. They were multi-kinase inhibitors. They messed up. They hit multiple different targets. There's a lot of toxicity. And then in 2017, we got smart and we sort of fine-tooth comb these inhibitors to decrease the toxicity and make them much more targeted. So rational drug design really revolutionized this space. So the two drugs that we have approved for patients with a RET fusion are selpercatinib and pralsetinib. As you can see, the response rate is pretty comparable, around 61%. And it's pretty well tolerated. If you look at these waterfall plots, so each of these bars is a patient. And whenever the bar goes down, that means that the patient is enjoying a response to treatment and the cancer is getting smaller. So whenever you see a waterfall plot fall down like a waterfall, that's a very good thing. So as you can see here, both of these drugs have great efficacy in this setting. And this is once again an oral agent. So we're going to move on to NTRK. Which is our last fusion that we're going to talk about today. And NTRK is actually seen in many different cancers all throughout the body, as are other fusions, as I had mentioned. RET can be seen in the thyroid, which I'm sure you've heard about. So let's talk a little bit about TRK inhibitors. So the reason I'm talking so specifically about them is TRK inhibitors were the first pill or tyrosine kinase inhibitor to be approved in a tumor agnostic fashion, which means it was approved across multiple tumor types all at once, which is very rare and very exciting. And larotrectinib really revolutionized this space. As you can see here, we have a patient here that's seen in our clinic that had metastatic disease to the skin here. And this is a patient on the baseline. Then you can see week 4, and then you can see week 12 on larotrectinib and how beautifully they did. So that was just a tour de force of the frontline setting. And if you don't do next generation sequencing on these patients, you're going to miss the opportunity to give all of those patients a pill, which can be revolutionary for them. So let's talk about the second line setting, which is going to be anybody that has already seen some kind of chemotherapy and had their disease progress, because there are mutations that are focused on second line therapy only. And those are these mutations. So let's start with our first one, which is ERBB2 or HER2. And that may ring a bell. You might think, oh, HER2, I know that's in gastric cancer. I know that's also in breast cancer. But as of late, we also found that it's present in lung cancer patients as well. So this is a drug that is targeting the HER2, which grows on our cancer cells, and it is known as an antibody drug conjugate. So antibody drug conjugates have three parts. There's the antibody, there's the warhead, which is the thing that's going to go and kill this tumor, and then you have the linker that attaches it. So I almost envision this kind of like the Trojan horse, right? The antibody comes in and it's hiding the linker inside of it. So then the tumor takes it in. So it's, you know, the antibody drug conjugate is floating around in your bloodstream, and then it attacks and binds to the tumor. And once it's taken into the tumor, it's almost like the Trojan horse opens up and reveals the army inside. And that's kind of like what I explained to my patients as to what's happening here. So this is an IV treatment. It is not an oral treatment. And this is very effective for patients with stage 4 lung cancer that have a HER2 mutation. But these patients have to see chemotherapy first. This is not approved off the bat Frontline. So the two antibody drug conjugates I'm going to talk about are TDM1, which has an overall response rate of about 44%, and then TDXD, or trastuzumab deruxtecan, which is the one I'm really going to be focusing on because I find it has slightly better efficacy. So trastuzumab deruxtecan has an overall response rate of about 62%, which is a little bit better than 44% on the prior slide that I showed you. Unfortunately, though, these drugs are kind of toxic. They can cause very bad nausea. They can cause really bad cytopenias. So you're thinking this is a patient that's already been treated with chemo. They may not have the most robust bone marrow, right? So then you're giving them this drug that's really going to knock their bone marrow down. So you need to be mindful and closely monitor them, have a low threshold to dose reduce, and you also need to worry about cardiac toxicity with these drugs. So I'm not sure if you remember in the breast cancer space, if you're going to give a patient HER2-directed therapy like Herceptin, right, you need to get an echo on these patients. So the same thing is true for patients with lung cancer. We need baseline echoes and then echoes every 3 months on these patients to make sure that we don't develop any cardiac toxicity. So I'm going to move next on to EGFR exon 20. If you remember, the first mutation I talked about was EGFR, and I told you there's 3 special EGFR mutations: exon 19, exon 21, and exon 20. 19 and 21, you can take a pill in the frontline setting. Unfortunately, exon 20 is like a totally different beast. You cannot take a pill in the frontline setting. There is only therapy approved against this mutation in the second line setting. And I'm going to talk to you about the 2 different approvals. So the first approval that we have is a drug called amivantamab. So as you can see, we are moving from small molecules to large molecules. So the osimertinib and the other tyrosine kinases approved in the EGFR exon 19 and 21 setting are too small to bind to the extracellular domain for patients with an EGFR exon 20 insertion. So hence birthed amivantamab. And amivantamab is a bispecific antibody that targets EGFR and MET. EGFR exon 20 is seen in about 1% of patients. So these are the 2 drugs that are approved in the second line setting for patients with this kind of EGFR mutation. Amivantamab is IV and mobocertinib is oral. These 2 drugs have not been compared head to head. So I can't tell you which one is better or worse. And they've also not really been sequenced. So no one really knows if you start with amivantamab, can you give someone mobocertinib if that doesn't work, and vice versa. People do it, you know, just off the cuff, but there really isn't much data looking at that. But hopefully if I'm ever invited back, I will have data to talk about this transitioning at some point in the near future. So I believe that the data is slightly better for amivantamab. As you can see here, the overall response rate is somewhere in the order of 40% compared to 28%. But really, you can't really compare them, and we're told not to do cross-trial comparisons. But amivantamab is an infusion, as you can see, and mobocertinib is a pill. Amivantamab has a huge risk of an infusion reaction, which can be kind of scary. So we need to give these patients antihistamines beforehand, and we have to coach them. Usually it can be very significant the first day, and then once you give them steroids and you pre-medicate them and they come back the second day, it usually does not happen. So you just have to prep the patient. Mobocertinib is just like osimertinib, that pill that I talked to you about. Rash and diarrhea can be a big problem, and it's even more pronounced in this drug. So let's move on to the final target I'm going to talk about, which is KRAS G12C. So this was once the undruggable. So I'm calling this section drugging the undruggable. KRAS is no longer the orphan. We used to get this mutation on that big 36-page document and just be like, oh, sorry, we have nothing for you. But now we do. So this space has been completely revolutionized, and it's really important because, as you can see, this mutation is seen in 13% of patients with non-small cell lung cancer. It's the most common mutation I've talked about today. So understanding that we have a target for this now is huge. So let me just walk you through this diagram on the right. It's a little bit complicated, but basically in the middle, you have your KRAS G12C mutated gene, right? So it's inactive. When it goes through the RTK and SHP2 pathway, this stimulates the gene to be GTB bound and it becomes active. And then it starts cycling, which then causes tumorigenesis, metastasis, cell proliferation. So it's some mechanism within the RTK SHP2 downstream signaling pathway that gets set off that signals this KRAS G12C to go from inactive to active. And in full transparency, we still don't really understand where in this signaling pathway this happens, which is why there are clinical trials right now looking at combining a SHP2 inhibitor and a KRAS G12C inhibitor. Or perhaps it's somewhere higher in the stream or lower down in the stream. We don't really know, because these patients have really aggressive disease and they really don't do well overall. The prognosis is poor. So we need to improve this space big time. So the two drugs that we have approved in this setting are sotorasib and adagrasib. These are swimmer plots. So each of these bars is a patient. And as you can see, the better they do and the longer they're alive, they keep swimming down the road. So adagrasib is a newer approved agent, which is why it doesn't look like the data is as good as sotorasib. I don't think we can compare these two yet, but there is some preclinical data that was presented at ASCO that adagrasib does have good CNS penetration. So that might be the take-home point here. So the good thing about these drugs is that the time to response is fast, right? You're like, okay, you have a big bad tumor. You didn't respond well to frontline chemo. We know you have this mutation. We've been waiting to give you this targeted therapy, but we knew we had to give it to you second line. You take this pill, it works fast, which is great, but the response and the longevity is kind of short. As you can see, it's somewhere in the order of 10 months for sotorasib. And sometimes it's less than that in full transparency. So it can be a tough sell in that setting, but if you have someone with painful metastases and you want a fast response, this is totally the right drug. Side effects can be real as well, though. Elevations in your liver enzymes can be significant, fatigue, GI toxicity with nausea, vomiting, diarrhea, and it's not really reported here, but myalgias. I have a couple patients that have weird aches and pains in their feet and their arms that I didn't even know was possible, but is a very rare side effect from this. Most of the time we can treat with steroids and it improves. So let's talk about the one targeted therapy that's approved in the curative setting in the early locally advanced setting. And that is basically osimertinib. So as you can see, the way that lung cancer goes is if there's a treatment that's approved in stage 4 and it works great in stage 4, then we try to see if we can move it into stage 3. If it works there, then we try to move it into stage 2 and to stage 1 and etc. So we are moving osimertinib, which is approved for patients with an EGFR mutation in stage 4, now to stage 3, stage 2, and stage 1 setting. So that's what I'm going to talk about next. So there was a study that was presented called ADORA. This was a large phase 3 study that looked at patients that had resected stage 1B to 3A lung cancer. So these patients got diagnosed with stage 1B to 3A lung cancer and they went for surgery for cure. And then after surgery, these patients got chemo, as they should get chemo. And after they finished their chemo, they then got randomized to get osimertinib, which is that EGFR inhibitor pill, or a placebo. And all of these patients had an EGFR mutation. So we were trying to see if adding that osimertinib pill prolonged their survival or prolonged their disease-free survival in this setting. And we actually found that it did. So these patients that took osimertinib versus placebo had a disease-free survival of 65.8 versus 28.1 placebo. So anyone that has resected early stage lung cancer that harbors an EGFR mutation, after they get their surgery and their chemo, you should talk to them about taking this pill. So let's go to some of the take-home points. Next month is November, which is Lung Cancer Awareness Month. So this month is also known as November. So in your med clinics, don't forget to talk about lung cancer screening. There's new lung cancer screening guidelines. So make sure that you think about your patients and advise a low dose CT chest for anyone age 50 to 80 with a 20 pack year history. Or quit within the last 15 years. So let's talk about some of the take-home points. Patients with non-small cell lung cancer can harbor multiple different actionable drivers, as you saw on the next generation sequencing data that I showed you. Comprehensive next generation sequencing is so important, and it should be done on tumor and on the plasma or blood. Tailor your treatment to your tumor. That is the theme of this talk. And if the next generation sequencing panel does not reveal anything, see if the lab can run RNA-based sequencing to see if you can find a fusion, right? You want to make sure you don't forget about those fusions. They're rare, but they can be life-changing. Just like that NTRK patient I showed you with that mass on the neck that got so much better, that could have been missed, right? So that's huge. Identifying KRAS G12C, which is undrugging that undruggable, EGFR exon 20 and HER2 mutations will impact treatment decisions, but this is in the second line setting. So if you find this mutation, kind of think of it as a weapon in your back pocket that if they progress on frontline therapy, you have things waiting in the wings for them, right? PD-L1 testing, I briefly mentioned that, but that's a whole other talk, but it's still important to make sure you get PD-L1 testing in addition to next generation sequencing. However, if you have a target, that trumps everything, and targeted therapy should definitely be employed more so than immunotherapy. We know patients that have a target do better with targeted therapy than immunotherapy. And molecular testing is moving into the early stage setting, as I had showed you, based on the ADORA data. So stay tuned for more of that. I just wanted to thank the entire thoracic team at MSK also for helping me with this talk, my MSBI family for inviting me back, and all of our patients. And a plug. So I am going to be walking in the Free to Breathe event that is going to be this Saturday for the Lung Cancer Research Foundation. It's this coming Saturday at 9:30 a.m. and we're going to walk across the Brooklyn Bridge. The weather looks amazing. So I would love to have you join me. You can sign up and join my team. You don't have to donate anything at all. Just come and walk with us. It's going to be a beautiful event. So feel free to email me any questions. And I put my Twitter below. And thank you. That's it.
Excellent. Thank you so much. That was amazing. And you'll be glad to know I already follow you on Twitter. So I think you're glad to know, because even though that means no extra Twitter followers today. Let's open the floor to questions. I'll let people either enter them in the chat or raise their hand.
I think Dr. Berger has his hand raised. Dr. Berger, do you have a question or comment?
Yeah, first off, thank you very much, Dr. Preeshagul, for an amazing talk, really incredible. I really, last year, for a different reason, had to look at some of the TKI inhibitors and their side effects, and your point around how we have to treat through unless they get to severe levels applies to so many different cancers that are being treated for this, not just lung cancers, but other cancers where you might have lung fibrosis and like figuring out when to stop, when not to stop. So it's really tricky. And I think for those of us in general internal medicine, always should be done in conjunction with our colleagues from oncology or from the organ specific areas where the damage is being done. I did have a different question though, which was early in the talk, you talked about the disparities in who's getting access to this stuff. And I wanted to dig a little deeper just because you talked about it. So in those studies where they were looking at it, by ethnicity or skin color or other issues, did they like control for who your doctor was, the access center, meaning like if you were living in a underserved urban area, did people all get the lack of access, and it's just depending on the racial clusters around access, or like was it sort of, there is an implicit bias in physicians about who get referred for genetic testing if you get seen at the same center?
So first of all, thank you for your comments, Dr. Berger. And I think you raise a great point and a deficiency in the study that I did not have time to get into. That this was a large retrospective study. And I think in order to encompass the masses of 14,000 patients, they did not have time to control for, running this study in the community versus a more rural setting versus an academic setting. So this was across all settings. But I think if you were to extrapolate out the data, I think it would be very interesting to see if this was really more true in the academic setting, or if this is more true in the rural setting, or if it's just that it's just a lack of knowledge altogether, or a lack of seeking care. I don't know where the barrier is exactly there, but I think the take home point is that it's not being offered. And I can't tell you how many second, third, fourth, sometimes fifth opinions I see, and a patient has not had this deeper testing, regardless of race, because it takes so much time, or the doctor doesn't know how to interpret the results, or they didn't have enough tissue, or they never were even asked. Or they just did that limited panel and they missed the fusions, or they missed the other genes. So it's all about getting the message out there and hoping that it sticks.
Thank you. Great answer.
Looking for other hands raised or questions in the chat.
Hi, actually, I have a question. Dr. Preeshagul, thank you very much for the wonderful presentation. I'm one of the interns at the MSBI program, and really happy to see that there's a lot of really great researchers out there going forward from the program too. One of the questions that I had was kind of thinking about what we can do for our patients. And, if somebody comes in and let's say they have 20, 30 pack year smokers, they're 50 to 80 years old, we want to offer them the low dose CT, but also sounds like there's a great opportunity to maybe use like liquid biopsies and sequencing to kind of take a step in the direction of early detection, and maybe use those tools as a better way to diagnose lung cancer. And knowing, of course, that lung cancer, generally, people who come in with lung cancer, they present a little bit later. So this sounds like a great opportunity. How can we bring this to the clinic and really educate more of our residents and maybe physicians to use these tools and to really improve these tools as well, so that we can use them to a better extent?
Dr. Drzik, you are ahead of your time. That is the question we all ask ourselves as of right now. I think, unfortunately, liquid biopsy is not approved in the screening setting as of yet. There are studies that are looking at it. We're trying to find the right panel. But if you think about it, it can also cause a lot more anxiety. Like, who are the right patients to do this liquid biopsy on? Right? Is it patients? Because we know there are patients with no smoking history at all that get lung cancer. Most of the patients that have those mutations I talked about. So is it them if they have a family history? Is it patients that meet criteria for low dose lung cancer screening? And what if you find a different mutation that had nothing to do with the lung cancer? Then you're kind of stuck reviewing, well, you have this, I don't know where it came from. And then you go on this hunt for a tumor somewhere, and it leads to anxiety. So I think we don't really know, this testing is not ready for prime time, because I don't think we know about the repercussions, and we don't know who's right to test. But I do think that it's something that may come in the future, and may fall on the internist to kind of be the gatekeeper here, to kind of run this test and then understand if there's something abnormal or not, and then refer out accordingly. So this may be coming in the future. Right now, we're using circulating tumor DNA or liquid biopsies in a clinical trial setting to follow patients to see if they're responding to treatment or not. Like, we have a clinical trial right now for patients with stage 4. that have an EGFR mutation. So these are typically Asian women, no smoking history. I will say that's not all the time, but commonly. And basically you check a liquid biopsy to look for the presence of that mutation before you start treatment. Then you start them on treatment, and at 6 weeks, while they're on treatment, you check a liquid biopsy again to see if they still have that mutation or not. And if they do have that mutation, then they get randomized to either get chemo plus the pill or the pill alone. And this is to kind of see if those patients that still have that EGFR mutation circulating around have a more angry disease, and maybe they would benefit from more. So we still don't even know what to do about these in a prospective setting. So I think we have a lot of learning, but I think you hit the nail on the head that this is coming, and it may be coming faster than we think. That was a long answer. Sorry.
No, that was perfect. Thank you so much. I really appreciate it. It's actually a very exciting field right now.
Yeah.
We have one of our residents, Dr. Matsuo So, who has a question.
Sure.
Hi, my name is Matsuo. I'm one of the PGY3 residents at BI currently. Thank you for the talk. It was amazing, like very comprehensive, like a drug therapy for lung cancer. My question is, so I'm originally from Japan. I had some training in pulmonary medicine, thoracic oncology. My question is like how we know more and more about the epidemiology data, like what kind of patients get to have more EGFR mutation, like East Asian female non-smoker population. Then now, like I'm glad we are all glad that USPSTF updated their guidelines, but still we're gonna miss a lot of non-smokers based on this current screening strategy. So I was wondering like how we can improve to detect lung cancer from non-smokers that falling off from the current recommendations. I think there's a cancer development related to air pollution recently presented in ESMO. We all know that radon is a risk and a family history. Even with all those information collected in like primary care setting, I think we're gonna still miss a lot of populations. So, and I think we know we have more and more evolving knowledge of these risk factors than faster than we can actually probably run trials, like big trials like Nelson or NLC. So like what's the future perspective of this lung cancer screening, especially in the US, I'm wondering. Sorry about the big question.
No, it's such a good question, and I appreciate you asking. I know there are some studies in development looking at trying to design a trial that will answer these questions. I don't know if it's gonna comprise of sort of a checklist of, you know, meeting with your primary care doctor and saying, have you had radon exposure? Have you cooked over a coal stove? What's your secondhand smoke exposure? And maybe if you get a certain scoring on that, like those other high risk features, and family history, like maybe that would set off a green light and that you would meet criteria for low dose lung cancer screening. But a CT is not a benign thing, and we don't want to offer screening or imaging radiation exposure to someone unless we know it's going to save lives, right? Mm-hmm. So I think it can be also a big ask, because you're also, you know, in some of these women also, they're going to get radiation to the breast, and you wonder, is this going to cause a secondary malignancy? You know, even though it's just one CAT scan, but we're doing it annually, when do we stop? So I think these are really good questions I wish I had answers to. And I get these questions all the time, and, you know, frustrated patients in my clinic, like, I've never smoked, like, I'm as healthy as a horse. Why did I get this? And why didn't my primary care doctor look for it? And hopefully we'll have the answer to that soon. And I'm sorry, I don't have a more definitive answer for you.
Thank you. Thank you so much. That's amazing.
Thank you.
All right, really interesting stuff. I think you, oh.
I just want to tell her that she did awesome, and it's amazing. There are so many amazing lung cancer doctors coming out of Beth Israel.
Isn't that amazing? Pot calling the
Thank you,
kettle
Dr.
black.
Lund. All right, well, that sounds like a good note to end on. Thank you for coming back and doing this. I really appreciate it. Thank you, everybody, for joining us.
Thank you so much for having me. Feel free to reach out if you have any questions. I left my email. I really mean it. I hope to see you at the walk.